Hello everyone, my name is Liesbeth Wildero van Wouwe. I'm a genetic counselor at the University Hospital in Ghent, Belgium, and a member of the HTAD working group of VASCERN. I would like to take you through this spill of knowledge about genetic counseling within heritable thoracic aortic diseases. Heritable thoracic aortic disease, or short HTAD, are disorders defined by the occurrence of a thoracic aortic aneurysm and/or dissection. We distinguish two groups within HTAD, namely non-syndromic HTAD with features limited to the aorta, and syndromic HTAD with, for example, Marfan and Lewis-Dietz syndrome. The aim of genetic testing in HTAD is the identification of a possible genetic background. We do this through blood analysis and to determine optimal care for each patient and allow effective family screening. To ensure patient safety, this testing should be done in a certified medical genetic facility. Patients with a known aortic disease can undergo diagnostic genetic testing. When a genetic cause is identified, the inheritance pattern is mostly autosomal dominant. This means there is a 50% chance of transmission to the next generation with an equal risk for men and women. If the diagnostic test identifies a causal variant, pre-symptomatic genetic testing is possible in healthy relatives. When the causal variant is present in this relative, specific follow-up can be set up. In case of absence of the variant, this person has a normal population risk. Genetic testing goes hand in hand with genetic counseling. This is a communication process to individual patients and their families to help them understand and adapt to medical, psychological, and familial implications of a genetic contribution. During genetic counseling, we collect, interpret, and analyze information to identify certain needs and address psychological, financial, and social concerns. We educate in an understandable manner about all kinds of topics and facilitate informed autonomous decision-making, access to personalized healthcare, clear intrafamilial communication, and all these steps aim to reduce the stress and anxiety often associated with genetic testing, and we also aim to create realistic expectations and acceptance of all test results, and we try to improve self-efficacy, patient knowledge, and satisfaction. In the ideal scenario, pre- and post-test counseling is performed by a trained healthcare professional. They are skilled in interpreting and delivering complex information using the tools displayed on the slide, and they adhere to core values like acceptance, authenticity, empathy, non-directiveness, and privacy. These are the core values of genetic counseling. The counseling takes place in close collaboration within the multidisciplinary teams, depending on the clinical characteristics and the genetic reports. Genetic testing and counseling, unfortunately, also has its limitations. The detection rate is not often very high, depending on the condition and the liberal or strict use of genetic testing. Also, a high prevalence of variants of unknown significance can make the results less clear than initially hoped. More genetic investigations can be necessary to obtain more clarity, and sometimes we get stuck in the gray zone without a clear causal variant. Other limitations are incomplete penetrance and variable expressivity. Incomplete penetrance means that not all carriers of a causal variant will eventually develop the disease, while variable expressivity refers to different symptoms that can occur with the same genetic condition. So this was a pill of knowledge for genetic counseling in HTAD. I hope you enjoyed it. I would like to conclude that genetic counseling is an essential component in diagnosis and management of patients and their families with HTAD. Thank you very much for your attention.